everyone. So this week we're going to be talking about managing quality and safety, chapter 17. And our objectives are to define quality assurance, explain its role in continuous quality improvement, discuss at least 2 general and 2 specific approaches to quality improvement, and examine ways to use them in practice, plan a model quality assurance program, identify the purposes for the types of records kept in public health agencies, evaluate a method for documentation of client care in the community setting. So, quality control. This is a tool we use to ensure effectiveness and efficiency, right? We want to make sure that the quality of care that we're providing is the best care possible, and that if there's any issue with the type of care we give, we can fix it right away, and so it needs to be monitored through quality control. Quality of care in the United States has a variety of definitions, and it can be really difficult getting comparable data, and they're trying to standardize that across the board, which is why they brought out, the big push for electronic medical records, so that things can be compared, benchmarks can be set, and care can be standardized throughout the country. So for anybody who had difficulty converting into EMR, this is part of why we do it. And consumers are rallying for quality healthcare. So, people who are getting healthcare, they want higher quality at lower cost, and they want total quality management. You hear people say, like, $10,000 for a hospital bill, and I still left sicker than when I came in, or something like that. Obviously, it's not always about customer satisfaction, but what they're trying to say is everybody who pays X amount to see a provider to get health care should have received the same care across the board. All right, so this says up here, quality improvement goals and outcomes. Oops. So quality improvement goals and outcomes, improving safety of care will save lives, right? So when we improve safety, we know that we are avoiding error, and error can cost lives. Cost reduction by using effective interventions. It increases client confidence in healthcare delivery regardless of setting. So it doesn't matter if you're at a private hospital or a public hospital. Again, standardization, quality of care, standard of care. Cost reduction by using effective interventions. So, we talk about effective interventions. So my biggest one is wet to dry dressing. 11 years or 12 years now in the healthcare field, and we're still using wet to dry dressings when it's cheaper and clinically proven better to use alternative methods. I don't know if any of you are wound care, but even just using a wound vac would be better. And so we talk about these, these more effective interventions and the cost reduction, and still it's not getting done. So you see that we have so much room to go. Performance information for the public. So we have report cards now. We actually just discussed our community health report card at the Cincinnati Health Department, which you can find on the HRSA website. Go to hrsa.gov, and then from there I think you can look up report cards by state, and we're in Ohio, and then you look for the city of Cincinnati. So health plan employer data and information set, that's called HEDIS, and that's our National Committee for Quality Assurance. So our HEDIS standards are what guide our practice and quality improvement projects in public health. And so that sets kind of the priorities and the standards and the goals for all of our practice in primary care. So for example, people who receive their vaccines, diabetics who have a pneumonia shot, diabetics who've had an A1C drawn in the last 6 months, diabetics who had their foot exam, hypertension that's controlled, smoking cessation, things that need to be offered across the board to everybody regardless of ability to pay. And this is the standard of care. And we look at these report cards to see where we can improve and compare ourselves against the national guidelines. And, some people say, some people complain about this. I personally think having these benchmarks are great because, for example, we weren't hitting our hypertension guideline standards. and neighborhood healthcare in Cleveland was. They were very similar community setting. So we asked them what they did, and we're trying to implement their same project. And that's getting that information out there is what helps everybody else improve. When you're isolated and you're not sharing your progress, it's really hard to self-assess, and see what improvement needs to be made. And communities also have health report cards. So there's health profiles, needs assessments, scorecards, quality of life indicators, health status, and progress reports. Obviously, the more urban or rural you get, the lower the community health report card is. I mean, just in general, access to food plays a big role. So if there's not a lot of grocery stores in a certain community area, you're already going to be low on that. That's what we call food deserts. So these are just kind of examples of the different report cards that we use in public health. So I don't like to harp on a ton of history when it comes to nursing stuff. I think it's important, but it's nothing you get quizzed on. Just this slide will kind of show you how it's evolved over time. Okay. All right, quality in the current healthcare system. Just so you can see that. Okay, quality in the current healthcare system. Historically, it often was accepted that there would be some problems or complications in the olden days. Even 15 years ago, open heart surgery. If someone died after surgery, it was like, okay, well, the alternative, they tried and you could die. I mean, open heart surgery used to be this crazy thing, and now it's not benign. It still is. I mean, I used to be an open heart ICU nurse, but with quality control, we have changed so much with the outcomes. So there's incentives in healthcare for prospective payment systems. Quality becomes important to reduce the number of complications that result in longer hospital stay. And also, it becomes cheaper. And I know it's hard. You don't want to say money isn't everything, but it is, because it affects access overall. It affects, driving costs of healthcare. And so, it used to be we just discharge people. People stay in the hospital forever, and now it's we discharge them so quickly, and that's because the longer you stay in the hospital, the more at risk you are for nosocomial infection and other complications. And now with community health, the need to be inpatient has gone away. I mean, the main reason you went to the hospital is because you needed nursing care. I mean, a doctor sees you a couple times a day in the hospital, unless you're in the ICU, and that's a different setting. If you need an ICU care, you need ICU care. If you're a med surg, your doctor doesn't see you all the time. The nurses take care of it for you. The nurses report on you. And so with this whole strive with home health nursing and community health nursing and telehealth and informatics, we can get people home sooner. And yes, there are a lot of people where you're like, oh my gosh, if we sent them home, they'd be worse off than they were when they started. That's not usually the case. Cases most people do better at home. And that has been studied and perpetuated into our quality care system. So definitions of goals. Quality. It's defined by the client as the improvement in health status. It's defined by the organization and providers as accurate intervention, the clinical context of care, and the skill of the provider. Quality health care. So the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So quality assurance, it helps us monitor the activities of client care to determine the degree of excellence attained in implementation. Constantly monitoring our care for quality is important because it helps us know that we're constantly at least hitting the standard of care, if not better. We have a bar set, and you want to always dip in and check and make sure that you're hitting that bar. Because no one ever wants to know that their parents, their loved ones, their family, their friends, themselves have received nothing but the standard of care, if not more. So goals of quality assurance are to continuously improve timeliness, effectiveness, safety, and responsiveness of programs. And when I say timeliness, I'm not talking about customer service like, oh, she didn't answer my call light soon enough to get me my ice chips. We're talking about timeliness in order to get people their care. timeliness in making sure that there wasn't a postoperative bleed, timeliness in answering that call light when someone had pain because they had an impending PE, timeliness someone getting their mammogram and catching breast cancer on time. Quality assurance helps us optimize internal resources to improve the health of our community. Total quality management. This is an approach to managing quality of care through appraisal of the nursing process after the client's discharge from the healthcare system. So you go back and you look at what happened. You post-mortem each visit to see where you can improve on. And continuous quality improvement is an approach to managing quality and emphasizes continual improvement in real time. So this empowers you to manage quality themselves and to make changes in organizational systems. And that's hard. I mean, I struggle with this every day with my staff. How do I empower my support staff, and I don't want to call them support staff, there's so much more than that, my team members, to manage quality themselves? I don't want to have to go back through people's charts to see where people messed up. I want them to do that themselves. And I even messed up where there were missing items, where they can improve and to make things more efficient. So quality assurance, QA versus continuous quality improvement. So quality assurance uses external determinants, whereas quality improvement uses internal determinants. And what I mean by determinants is what we're determining, what allows us to determine what's quality. And so with quality assurance, we look on outside benchmarks, and we post-mortem visits. Internal determinants is we have our own set standards, and we are constantly comparing ourselves to them. Quality assurance helps detect errors, and continuous quality improvement determines requirements and deficiencies and expectations. So where can we help hit things? Whereas quality assurance, we're looking for things that we did wrong. Quality improvement is where can we improve? Where can we get better? And this, it goes on and on about all the different parts of it. Obviously, quality improvement is the winner. It inspires hope. Everybody else is involved. It doesn't assign blame, and it's more preventative. We're looking for potential issues, before they happen. So approaches to quality improvement. General approaches seek to protect the public by ensuring a level of competency among healthcare professionals. So, make sure everyone's credentialed, licensure. Get people certified. Med-surg nurses are certified in med-surg. I mean, that makes them experts in the medical surgical field. Hem-onc nurses are now all certified. I mean, it's across the board. We're trying to improve all of our level of care to the point where we're experts in it. Wouldn't you want a nurse who's an expert in wound care, taking care of your wounds? Wouldn't you want a nurse who's an expert in recovering open hearts, recovering your parent? And then charter recognition and academic degrees. This is why you guys are all going back for your BSN. And you might think, oh my God, this is so pointless. I hate this. I get it. I get these classes don't seem as important as what you learned in your original RN degree. And to a point, sure, I think there's something to be said going back for your BSN and doing the RN stuff first, because you do focus on that critical, just straight nursing care. And now you're back here talking about quality improvement, but this academic degree, okay, now you know what quality improvement entails, and you can go and bring that back to your setting. And a BSN nurse is best at doing that through studies. I don't know. All right, specific approaches. So total quality management, continuous quality improvement, traditional quality assurance, staff review committees, utilization review, risk management. We've all heard it, right? Basically, what are our specific approaches to improve quality? We're constantly reviewing things. We have quality improvement committees, and we look at our risk management. We look at our utilization review. We go back and say, okay, last month we utilized X amount of sitters but we didn't utilize this many restraints. And then how did that improve bed sore numbers and nosocomial infection numbers and fall risks and stuff like that? So that's how you can approach it. So the primary purpose of a quality assurance program is to ensure that the results of an organized activity are consistent with the expectations. So you have your structure. So what are your objectives? Your process. What way are you going to appraise what quality improvement measure you're looking at? And then your outcomes. So what outcome standards are you going to evaluate against? And then you're going to want to evaluate, interpret, and put into action. in the end, documentation is essential to the evaluation of quality care in any organization. One, it keeps records, right? But the other thing, too, is it helps you go back and say, okay, in the transplant floor, we had this problem with urinary catheter nosocomial infections. How did they improve their rates so that we can implement that on the, burn unit? And you go back and you look at that quality improvement project. Healthy People 2020. So we talk about, Healthy People 2020. It's a big way that we set all our goals. All organizations set their goals to Healthy People 2020. And we document to prove that we tried to hit those goals and provide quality health care. And if you go back and you look at the postmortem report on Healthy People 2010, you see how we improved on things and why documentation was so important. Okay. So that is the end of this lecture, and we'll meet again on Chapter 18.